Welcome to this session. My name is Hamish McAllister Williams. I'm the Director of Education for the British Association for Psychopharmacology, and it's with very great pleasure that I introduce this session this morning. And I would like to thank the organisers of the conference for arranging for a group of us to come from the British Association of Psychopharmacology to run this course on bipolar disorder today. I will introduce the other two speakers as we go along. You're hopefully familiar with the plan for today. This is the programme in outline. There's going to be a brief introduction, which I will do just now. We will then move on to the pharmacology of mood stabilisers that's going to be given by Professor Nicol Ferrier, who's been key in organising this particular meeting. We will then move on to pharmacological management of mania prior to coffee. And after coffee, we will then look at the pharmacological management of bipolar depression and long-term management of bipolar disorder. There will then be lunch and also the introductory lecture for the conference as a whole before we restart at 3 o'clock. And at 3 o'clock we're going to have more interaction, more questions and discussion. And we are going to start off by talking about three particular special topics in bipolar disorder: treating bipolar disorder in pregnancy, treatment refractory depression, and rapid cycling. And we are going to do those sections in a very open discussion way. There will then be some more general discussion with all of the speakers, and then after afternoon coffee we have some cases, some brief descriptions of cases that we're going to break into small groups, go through and think about how we might manage those individual patients. So just to remind you that all attendees here will receive a certificate of attendance that will be handed out this afternoon. In addition, we will be emailing everybody here the slides. All the slides that are presented today will be emailed to all of the delegates, hopefully sometime today. Is that correct, Sarah? Yep. So Sarah is telling me yes. So there's a lady in the back corner, Sarah Channing Wright. She's waving. Sarah is one of the BAP office staff, and she's kindly come here to this meeting with us to help run things, help organise things, and also answer any questions that you might have. One of the things, or just to introduce something about the British Association for Psychopharmacology, it has been around now for over 40 years, with it being founded in 1974, and it has twin aims of promoting research and education in psychopharmacology. Although it is called the British Association of Psychopharmacology, it is very much interested in the biology of psychiatric illness in general, not just purely the use of drugs to treat psychiatric illness. In the UK, the British Association, the BAP, is recognised as the leading provider of independent psychopharmacology education. All of the education that is provided completely free of sponsorship from industry. We do engage with industry quite widely in the BAP, but not with regard to the education, because we believe it is important that clinicians are able to gain education that is completely independent. And we run both preclinical and clinical education. We have face-to-face meetings, which we refer to as masterclasses and clinical certificate courses. We also have an online continuing professional development resource, CPD resource. outlined here. Now, as delegates to this satellite meeting, you will be given access to this online resource. And again, today, when the slides are all emailed to you, you will be provided with details as to how to log on to that by Sarah. And Sarah will be available at the coffee break this morning and this afternoon to also demonstrate the online resource. But I was just going to very briefly show you what is on the online resource. It's aimed at primarily psychiatrists, but it's relevant for all those prescribing medication for patients with psychiatric illnesses. And it's presented, and this is somebody else who'd written this, not me, but it's presented by knowledge experts and opinion leaders in the fields that the various elements of the CPD cover. Most of the modules commence with covering the basic pharmacology of the drugs involved. This is because we strongly believe that to be excellent clinical prescribers, you need to understand something about the basic pharmacology of the medication. And today's course will follow a similar pattern in that the next presentation will be on the pharmacology of the drugs. The other important point is the resource is also constantly updated to make sure that it is cutting edge with regard to the treatment of bipolar disorder. So this is what you see if you go to the website. So this is at the BAP website, which is bap.org.uk. And then you have this menu down the right, and you can select Online CPD Resource. And if you do, you end up with this page. So there is a brief video that just explains about the resource. And then you can see there are two elements. There's modules, and all these various topics, and then there are published paper reviews. So those are the two elements. Didactic, teaching modules, and then reviews of psychopharmacologically related papers. So just looking at the modules, this is a list of all of the modules on the resource. So you can see it is very comprehensive, covering the range of disorders that we deal with in psychiatry. Let me take an example of schizophrenia. And this module is broken up into 4 topics. So it starts with the topic of the pharmacology of antipsychotics. Then we have treatment of first episode and acute psychosis, relapse prevention. Then we move on to strategies for treatment refractory, treatment resistant schizophrenia, difficult to treat schizophrenia. And then there is a topic on adverse effects of antipsychotic drugs. Each module is broken down slightly differently, but as I say, most start with basic pharmacology, and many of them include how to deal with difficult to treat patients. All of these presenters here are all acknowledged experts in the area of the psychopharmacology of schizophrenia. Just to illustrate it a little bit further, let's take one of these topics, and each topic is then broken down into a number of different sections. So this particular topic on treatment-resistant schizophrenia is divided into 4 sections listed here. There is a particular reason for that, which I'll show you in a second. Let me illustrate this by looking at one of them on clozapine. So if you go to this section, this is what you get. You get a series of slides with an audio commentary from the presenter. Each section is quite short. This one is just 10 minutes long. And we have designed the resource so that it is short elements so that you, in your busy lives, don't have to sit down and listen to a whole hour's worth of a lecture. You can get it in small chunks that fits in better with people's day-to-day working lives. When you're looking at the slides here, so here is just the slides. There is a navigation at the bottom, and right at the bottom, I'm not sure whether you're able to see that, but right at the very bottom, there are some lines. Each of those lines indicates when there is a new slide, and then there are smaller lines. You probably can't see those, but there are smaller lines, and they show where a slide builds, when more information comes onto the slide. So you can see precisely where you are within that topic. This little bar here shows you where you are in the topic and when you're going to get to a new slide. And you can navigate around it. You can navigate to different slides, or you can navigate around the individual slide if you want to review things. So it makes it very easy to look at. We have a new module on old age, and I'm showing this simply just to show you that things are fairly comprehensive in the resource. So we have management of Alzheimer's, agitation in Alzheimer's, Lewy body dementias, vascular cognitive impairment, frontotemporal dementias, delirium. But then also importantly down here, we have management of late life mood disorders and treatment of late onset schizophrenia. So that we're able to look at some of the more complex situations beyond the modules such as the schizophrenia one that I've just shown. And also importantly, we have a module on general psychopharmacology, which covers topics such as pharmacokinetics, interactions, adherence to medication and what you can do to promote adherence to medication, individualized prescribing, how to target treatments for individuals. It's actually using a specific example of treating somebody, sports people, with psychiatric illness. And then using licensed medicines for unlicensed applications, a really common thing that we do in psychiatry. And also audit, and how we can use audit to improve the quality of our psychopharmacology. So it's a very, very comprehensive resource. Each of the topics lists additional reading, and each module, so the module would be schizophrenia or bipolar disorder, has a set of multiple choice questions. So at the end of a module, you can complete the multiple choice questions, and if you get above a certain cut-off threshold score, you will then be able to get a certificate confirming your completion of that module. So you can check your knowledge. Importantly, we've also now got an iPad app, if you do have an iPad. I think, Sarah, does it only work on an iPad rather than an iPhone? Yeah, okay, so it just works on an iPad. But what you can do is you can download modules to view them offline. So if you're sitting on an aeroplane, you can be looking at some of this work. And you can also complete the MCQs. And then when you go back online, it all gets updated. All of this material gets reviewed every 6 months to check that it remains up to date. And then just finally, very briefly, we have these reviews of papers on the resource. There are currently 189 reviews on the resource, and there's another approximately 40-odd that are in the process of being added. And you can look at these reviews in 3 different ways. You can just look at them all in date order, and just look at the most recently added ones, or you can search for particular drugs or particular disorders, or search for keywords. This is what you get. This was putting in bipolar disorder. So there were 24 items for bipolar disorder. We've got various different ones down here. And I've chosen the second one, valproate exposure during pregnancy and risk of autism in the offspring. There's a brief summary just to tell you what the paper is about. And then you get this. You get a 2-page summary of the actual paper. So, you get a brief introduction about the topic and the study that was done. And then you get the important findings sort of listed as bullet points to make it very easy to take away the key issues. Get the conclusions and then any comments about this. We're really very, very grateful to Professor Andrade from India, who does these on a very regular basis and sends them around a lot of psychiatrists around India, and he gave us permission to be able to use these reviews on our resource. So we've taken the ones that are particularly psychopharmacologically related and put them onto the resource. And they really are excellent reviews. I can highly, highly recommend them. And they're an excellent way of keeping up to date with a lot of the literature that is coming through. So while this resource was initially aimed at UK clinicians, it's got a growing international profile. So, for example, it is provided to ECNP school delegates. And we have now subscribers from a number of countries around the world. And we have non-UK presenters that are also involved in providing some of the material for the resource. And I've already mentioned this, so the point about this is that this resource is completely independent of industry, and there are declarations of interest available for each of the speakers. So this resource is a very comprehensive textbook of psychopharmacology that has the benefit of being constantly updated. There are MCQs to test knowledge, and there are reviews of recent papers to help you maintain up-to-date knowledge base. And I really hope that you enjoy the resource and make use of it. As I say, this will be available to all of you. If you have any questions or any issues, please get in touch. We are very keen to try and ensure that the resource is made as useful and as user-friendly as possible. Now, we will now move on to the first presentation of the actual section, and it's a real pleasure to welcome my friend and colleague from Newcastle University in the UK, Professor Nicol Ferrier. Nicol has been very much involved in putting this entire program together. He's led on putting the program together, and he's going to be talking about the pharmacology of mood stabilizers. Nicol.
Thank you very much, Hamish, and good morning, everybody. Thank you very much for coming. So it's a great pleasure to be back here at the TAP meeting in Antalya. I was here last year and I enjoyed it very much, and looking forward to this meeting and all the exciting things. So as Hamish mentioned, when we do the clinical review of an area, in this case bipolar disorder, we think it's useful to review the pharmacology of the drugs used in that area. And so I'm going to give a hopefully a relatively brief talk about the pharmacology of mood stabilizers. And what I want to do is to look at practice points derived from the pharmacology, so what the pharmacology can tell us about how we use these drugs in practice. I'd also have a review of what the mechanisms of action of these drugs might be. And of course, it's ultimately by understanding the mechanism of action of these drugs that we'll be able to develop better drugs to be able to treat our patients better and to avoid major side effects and difficulties. So the understanding of the mechanism of action is crucially important for the future, but it's also has some relevance for day-to-day practice as well, as I hope I'll point out. So the drugs I want to talk about this morning are the so-called mood stabilizers, and of course that leads to the question of what is a mood stabilizer, and you may be aware that there are all sorts of different definitions of what a mood stabilizer is. And some of the drugs, for example, antipsychotics, are known to have mood stabilization properties in that they can help with bipolar depression, they can treat bipolar mania, and they can also provide some prophylaxis for the future, which is what most people use as a definition of a mood stabilizer. But I'm not going to talk about them this morning, about the antipsychotics and their pharmacology, but I'll focus on the more conventionally called mood stabilizers, that is lithium and the anticonvulsants valproate, carbamazepine and lamotrigine. And as we'll be going through this morning in the taught section of this meeting, all these drugs have evidence for mood stabilization properties in bipolar disorder. So these are the drugs that I'm going to be focusing on. Now, starting off with lithium, it's of course a monovalent cation, and what that means is that when you give it to someone, it has a very widespread distribution within the body, within every cell of the body, very widespread distribution and therefore widespread effects. And of course we know it's a drug that can be used in a number of situations, not just in bipolar disorder, which is actually very interesting thing about lithium, but we won't be touching on too much of that today. When we give lithium, its absorption and distribution is very swift, so there's a very rapid uptake into the body, a very rapid distribution within the body. Elimination of the body is almost exclusively renal, and this is very important for clinical practice, since we know that in the elderly and in those who've been on lithium for a long time, renal function gets compromised, and therefore that leads us to need to check the lithium level more frequently in those who have any degree of renal failure or any degree of renal compromise. It's a drug with zero-order kinetics, which is very useful, which means that you can predict the level. If you can do a level at one point and then at another point, you can predict what it will be at the other point, since it falls exactly in a zero-order way. The only other drug which we, in psychopharmacology, which is zero-order kinetics, is alcohol, which also has the same thing. You can predict the level of alcohol an hour or so after a particular level, if you know the rate of fall of it. So it's a very simple drug in some ways to work out blood levels from because of this phenomenon. It's got a half-life between 18 and 24 hours, which increases with age. And again, that's another factor that leads us to want to check lithium levels more frequently in the elderly. And a very important point about the half-life is that the half-life in the tissue, and particularly in the brain, is much longer than 18 to 24 hours. So if the drug gets into the brain, the drug does get into the brain, if it's in high levels in the brain such that it's causing toxicity, then it will take a longer time for that lithium to leave the brain once the drug is stopped. So it's very, actually slowly gets out of the brain once it's in the brain. And as we know, there's a very narrow therapeutic window, a very small gap between within which the drug is effective without causing major side effects. Now, the toxicity is well known, I think, to all of you here, and the range of toxicity is up here, from very mild symptoms, for example, nausea or some diarrhea, and a very marked fine tremor, which is common in most people taking lithium, and polyuria. These are very common symptoms, up to very severe symptoms, which are described there, including, of course, severe ataxia being a very common marker of toxicity, and eventually coma and, of course, death. And some of the changes that we can get with high levels of toxicity become irreversible. So it's very important to look out for these symptoms in patients. And what we recommend is that all patients are given information about the side effects of lithium and about toxicity, so that they know when there are symptoms that they need to worry about, and so they can get medical attention earlier. So it was a very important piece of patient information that they have this information to know about the levels of toxicity. Because, as I say, if some of these toxicity things can be irreversible, if they have severe toxicity for a prolonged period of time, then that may become irreversible. Now, a very important point which we need to remember as practicing clinicians is that the blood level that we get when we take blood sample, it doesn't reflect very closely the level in the brain, and it's the level in the brain that can cause the severe symptoms and those that become irreversible. And it's now known that quite a lot of patients can have lithium toxicity even when their blood level is normal. And examples of where that might happen are renal impairment, dehydration, and also the interaction that there are with other drugs, for example, non-steroidal anti-inflammatory drugs, ACE inhibitors and so on, can often be associated with relatively normal levels in the blood but high levels in the brain. There's an association between toxicity at normal levels and the use of high dose of antipsychotics as well, which is another cause. So it's also important to not just look at the blood level, but look at the patient's symptoms in trying to work out whether the toxicity is present. Now, what about how do we achieve the dose? First of all, what dose range is recommended? Well, most people, I think we should still be aiming for a blood level of between 0.8 and 1.2 nanomoles per litre. There's been a tendency recently to go with lower lithium levels of, say, 0.5 or 0.6. But I think most evidence in bipolar disorder suggests that you will get better effects, both in bipolar depression, but also in prevention of episodes, and certainly in the treatment of mania with levels between 0.8 and 1.2. So that should be our target level. Most commonly, we get to that dose by titration, so we give a dose, then measure the level, then increase the dose a bit, measure the level again, and so on. But it can be done by calculation, and an example of the calculation has come from some well-established papers is shown here. I won't go through it now, but you can calculate the lithium dose required based on the weight, and an estimation of the creatinine clearance of that patient can get you to a dose that will then predict the serum level you're looking for. And there is a difference between males and females on this, of how one gets to that final dose. But I won't go through the detail of that, but these methods are available. But I think most authorities would still recommend that we titrate and very more gradually get to the correct level by titration, although there are some cases, of course, where it's very important to get the level up quickly, in which case one could use a method such as this calculation. There's also a question of whether the drug should be given daily or twice daily. Most authorities now recommend once daily because there's some evidence that this is less likely to cause renal impairment, which is a long-term concern of the disorder, and of polyuria. So single-day dosing is recommended from that point of view. There's also the issue that you can get much more a clear picture of the blood levels by using single dosing. And for example, if you give twice daily dosing, you have a lower trough level, as is demonstrated in this picture here. Actually gets you a lower trough level. So twice daily will lead to quite a big fluctuation in the dose levels and overall a lower trough level. And we think it's the level of the trough that's important in terms of clinical activity. And using it twice daily can also have an impact on how you find doses. So the recommendation I think we have, unless there's some strong reason why not, is to give it once daily. Now, what about valproate? Various preparations are available. I'm not going to go through those today. Essentially, they're all the same and produce the same chemical moiety, a chemical substance, valproate. Now, here there's a very different situation regarding the dose. It's guided by serum levels. Now, serum levels are not commonly measured. In fact, most authorities suggest that there's no real indication for measuring valproate serum levels. But you can roughly get an indication of the serum level you have by the dose you give. And so when you work that backwards, what we notice is that if you have a blood level of less than 45 milligrams per litre, it's unlikely to be effective. The range we want to get to is a dose that will get us to a blood level of between 60 and 90 milligrams per litre. In most cases, this is around 1,600 milligrams of valproate, and that's probably optimal. There's some evidence that in very severe cases of bipolar disorder, particularly with severe rapid cycling and mixed affective states, that higher doses, which would produce higher blood levels, may confer benefit in some cases. But it's very clear there's a trade-off here between clinical effectiveness and side effects, because side effects with the drug are very common if levels higher than 125 milligrams per litre, particularly nausea and weight gain, but also the risk of hepatic dysfunction, which can be very severe, neurological problems such as tremor, and also blood problems can develop with these higher doses. So in most cases, we want to stick to the standard dose and be very aware that higher doses may lead to all these different complications. Now, in this particular case, there are some problems with lithium that I've highlighted with interaction with drugs, but there's also a number of interactions with valproate that we need to consider. And one of the most important of those is with the other mood stabilizer, lamotrigine. And here, lamotrigine, the effect is that if you have valproate, then it reduces the clearance of lamotrigine, and so you have to have half the dose of valproate, half the dose of lamotrigine if someone is on valproate. Carbamazepine has the opposite effect. Carbamazepine decreases valproate levels, So someone who's on carbamazepine and valproate needs to have a higher dose of valproate. And these may be indications for measuring the blood level if that's available. It also interacts, I won't go through it, with tricyclics and with aspirin. One of the most important things about valproate, of course, is that is the risk in pregnancy. And we now know that the risk of neural tube defects in offspring of mothers on valproate is very high. It's 3 times the normal rate of severe birth defects, which can have major impact on the child. We now also know that the child of a mother who was on valproate is likely to have cognitive impairment, and it's estimated that at year 3 of a child born to a mother on valproate, there will be 10 lower IQ points in that child on average. Now, some of that data comes from mothers with epilepsy and not from bipolar disorder, but there's no reason to suppose it would be different in bipolar disorder. So for these reasons, our recommendations in the UK is that valproate is not given to women of childbearing potential, so women in the range where they could become pregnant or who are not on very adequate contraception. If someone has to stay on valproate and become pregnant, or becomes pregnant while on valproate, one can give high-dose folic acid to try and overcome the risk of neural tube defects, but the evidence that that's likely to be successful is very weak. And all in all, what we want to do is prevent any risk to the unborn child, and so valproate should be given only with extreme caution in women of childbearing potential. Now, what about lamotrigine? Well, here we don't actually have regular serum levels, and here we're guided by the dose. First of all, there's the very low dose that we might need to give if someone was on valproate. Remember, the clearance of lamotrigine is reduced if on valproate. So in that case, we need to give lower doses. The usual range is between 150 and 250 milligrams per day, and with that, most evidence suggests you'll get benefits in bipolar disorder. But in severer cases, then the dose needs to be increased above 250 milligrams per day, but this is limited by the risk of ataxia in higher doses. And if people get ataxia, the dose needs to be reduced again. So ataxia is the thing to look for if using higher doses. In all cases, the dose must be increased very gradually, as per the instructions in the booklet, to avoid the risk of the Stevens-Johnson syndrome, which can be fatal and has been fatal in some cases. It's not metabolized, it's metabolized by the liver, but it doesn't induce enzymes, and so that's not the cause of the interaction, it's due to other factors. So these are just some of the factors involved in the prescription of lamotrigine. So I want now to move on to the next issue, which is looking at the overview of the mechanism of action of these drugs. And here, it's obvious, the situation at the moment is that we're still unclear as to what the mechanism of action is. And it's very likely, in fact, that it's not one mechanism of action, that in fact are multiple mechanisms of actions that lead to a clinical benefit. So trying to break that down and look at the different ones, I'm going to look at the effect of these drugs on the neurotransmitter systems, on the monoamines and the amino acids. I'm also going to look at the effects on signal transduction, how the brain works in terms of sending signals to cause changes, and do the drugs interfere with those mechanisms. And finally, the issue of whether these drugs are involved in cellular resilience or in neuroprotection. It's quite obvious that the effects in bipolar disorder are particularly interesting and unique, because what the drugs are doing is having a particular effect to prevent something happening, to prevent someone going high or to prevent someone going low. So how the drug works in doing that rather complex thing, rather than treating depression or treating mania, it's actually preventing depression and preventing mania, is quite complex. And that's led most people to believe that although there may be direct effects on monoamines and on amino acids, the effect on prevention of episode, on prophylaxis, is due to their effects on signal transduction and how these drugs interfere with the mechanism whereby signals can lead and escalate into problems in patients. So let's start off by looking at the neurotransmitter systems, which are outlined here. And the first one, the most important one I want to look at, is dopamine. And we know that dopamine is very important in bipolar disorder. And it's almost certainly the neurochemical that's involved in mania, that mania is a hyper-dopaminergic disorder. One of the reasons we know that is if you give amphetamines, it will cause, in normal people, to have a very low degree of manic-like symptoms. But if you give that to people who have got bipolar disorder, if you give amphetamines to bipolar disorder, then that will be increased very much. So here's some old data. You can't do these experiments now because they're unethical. But if you gave, if you look, for example, at the Young Mania Rating Scale, which is in the right-hand column of this picture here, and gave amphetamines to healthy subjects, then some of them develop a very low level of manic symptoms. But if you give them to people with a history of bipolar disorder, then they develop very marked mania or manic-like symptoms with a high Young score. So it's thought that the bipolar patients are sensitive to dopamine, the dopamine excess that amphetamine brings and causes symptoms. Now, amphetamines release both noradrenaline and dopamine, and it's still unclear as to whether these effects are mediated by noradrenaline or by dopamine, but most people believe that the dopamine is the most important part of that. Another very interesting experiment that points to the importance of dopamine in mania is the experiment done in Oxford in the United Kingdom using tyrosine depletion. Now, tyrosine is an important step along the way between, in the production of dopamine, and you can actually deplete the amount of tyrosine in the brain by giving a particular form of amino acid drink. So if you give a drink which is full of BCAA, which is branched-chain amino acids, then the amount of tyrosine in the brain falls, and so does the amount of dopamine. And in a very kind of interesting experiment they gave patients with mania branched-chain amino acids, which depletes dopamine. And here is placebo, and here is the patient on the branched-chain amino acid, depleting tyrosine and therefore dopamine, and there was a reduction in the manic symptoms in those patients. So these are some of the evidence that we think that dopamine is involved in mania. So what does lithium do? Well, lithium blocks dopamine release. First of all, it also alters the behavioral effects of amphetamine. This is an experiment in rats, where rats were given amphetamine, and the amount of activity that the rat had is measured. And in the red line is what happens when amphetamine is delivered. The animal becomes hyper active and starts all kinds of behaviors, particularly circling behaviors. It's found if rats are given amphetamine. If the same rats are on lithium and are given amphetamine, there's a much blocked effect. So it's blocking dopaminergic behaviors. And we think this might be due to a reduction in the amount of dopamine released presynaptically. And this is an experiment we carried out in Newcastle, where we looked at dopamine coming out of a cellular preparation. And when the cells are stimulated, there's a high release of dopamine in this preparation. If the animals are on lithium, then that's blocked. So what lithium seems to do, and this may be why it's anti-manic, is to block dopamine. And this can also be demonstrated in humans, and this was the results of a study done by a colleague of mine in Newcastle. And what he did was give methamphetamine to normal subjects and made them do a psychological task, and at the same time scanned their brain. And when you did that, there's a lot of activity in the frontal cortex and the parietal temporal cortex when given amphetamine while doing this psychological task. And then half of the subjects were put on lithium and half on placebo. Lithium itself had very little effect on the brain. But when you gave methamphetamine plus into the people who were on lithium, the effect was blocked. So this is a dopaminergic activity, we think, from all sorts of animal experiments will tell us that this is related to dopamine activity, and that was blocked in the human subjects who were on lithium. So the same phenomenon seems to occur in humans. And that's almost certainly why it has anti-manic properties, but probably not why it has a prophylactic benefit. It explains that part of its symptoms. Valproate also has the same effect of blocking dopamine, and this shows a human study where you can look at the uptake of a particular chemical in the brain which measures, which gives you an index of the amount of dopamine release. And here, subjects were, before treatment and after treatment with valproate, the amount of dopamine release that they showed when given this test, was reduced, with no change in receptors. So the change again is presynaptic. There's a reduction in dopamine release on people on valproate. And again, that might explain the anti-manic properties of valproate. Now, what about 5-HT function, serotonin function? Well, lithium is particularly important here. And lithium is thought to enhance serotonergic function. And so there's evidence from preclinical studies, which I won't go through in detail, but if give lithium to animals, you can demonstrate changes in 5-HT, which suggest that it's increasing 5-HT release. And there are clinical experiments in normal subjects and in patients which suggest the same effect occurs there. And it may well be that this effect of lithium on 5-HT is responsible for the antidepressant effect of lithium, and also the augmentation of antidepressants. And so you know that patients on antidepressants, when added lithium, will get a better clinical response, and that's probably due to its effects on 5-HT, particularly its enhancing of 5-HT receptor supersensitivity. Lithium has also been shown to be anti-suicidal in bipolar disorder, but also other affective disorders, and it may well be that this anti-suicide effect is due to this effect on 5-HT. Now, what about amino acids? Well, the amino acid system, GABA and glutamate, are very important in that they regulate the neurotransmitter systems. And this slide shows the dopamine pathways in the brain, marked here in red. And what we have in blue and in green are the GABA and glutamate systems, glutamate in blue and GABA in green, which are the inhibitory and excitatory neurons controlling, regulating the dopamine system. And they're mostly found in interneurons in the cortex, particularly GABA. GABA is known to be an inhibitory interneuron in the cortex, and glutamate an excitatory one. Well, what do the mood stabilizers do in terms of these two important amino acid transmitters? Well, they're metabolized in this way. In the brain, there's this metabolic pathway for GABA, which is then released and has its effects on the neuron. GABA is then recycled extracellularly into this. So there's this pathway for GABA in the brain, and there's a similar related pathway for glutamate of recycling from extracellular sources. Now, what the mood stabilizers do, and I'm not going to go into a lot of detail here, is that they have effects on these systems so that, for example, valproate will enhance the GABA acid decarboxylase, so more GABA is produced. It will also block here this transfer back. So what happens is that you get lots of GABA, both intracellularly in the system, but also extracellularly as well. So valproate enhances GABA release, and GABA tissue levels increase. And valproate also has an effect on glutamate, in decreasing glutamine transmission by blocking the receptors. Lithium has a similar effect. It increases the release of GABA and increases the uptake of glutamate. And carbamazepine lamotrigine also enhance GABA release and have effects on blocking glutamate. So essentially all of these neurotransmitters enhance GABA by one mechanism or another, both in terms of the transmission but also in terms of tissue levels, and they block the effects of glutamate. So they're enhancing inhibition and decreasing excitation. And that's summarized in this slide here. The main drug that we know works through this mechanism is valproate, which has all these different effects on GABA. But all three of the drugs, lithium, valproate, and carbamazepine, increase GABA tissue levels, increasing the inhibitory transmission. And glutamate is the opposite. In most cases, there's evidence of blocking the glutamate levels and decreasing the amount of activity through the receptors. So this is thought to be at least one mechanism whereby these drugs produce their prophylactic benefit. But there may well be others, and the signal transduction method systems are almost certainly also involved in the long-term effects of these drugs. And there's three particular areas of second messenger systems, the inositide cycle, the protein kinase C and glycogen synthase 3 beta that are important. I'll just briefly run through them. This is the PI cycle, which is very important for the signaling of a number of receptors in the brain, some of whom are outlined here. And this cycle is activated when the receptor is activated, and this cycle here produces activity, but also fosters protein kinase C, which is very important in regulating a number of transmissions within the brain. And lithium blocks this transmission here, this cycle, by blockade of these two enzymes here, so that the effect is to inhibit phosphokinase C. And the effect that lithium blocks these enzymes can be demonstrated in human subjects. So we know that the blocking of the cycle happens, and we also know that reduction of protein kinase C occurs with lithium, and it also occurs with valproate. We know that in mania there's increased protein kinase C activity, and that's shown here on the left. And it's thought that this is an important mechanism that can lead to effects in bipolar disorder. And one of the ways in which that is thought to have been shown is with the drug tamoxifen, which is a protein C inhibitor, also used, of course, in the prophylaxis for breast cancer, but it's a protein kinase C inhibitor, and it is anti-manic. I think the first demonstration of that was in Turkey, and then a second study was done in the States, a larger study showing tamoxifen, a PKC inhibitor, produced anti-manic effects. So lithium will block the cycle, the PI system, which can cause acceleration and can block and dampen that. It can also reduce PKC, and reduction of PKC may well be important in the mechanism of action in bipolar disorder. And finally, there's the action on GSK3 beta, in which you have a number of experts in Turkey on this particular subject. We know that activation of this GSK3 beta is very important, particularly in the dopamine system, and GSK3 beta is important in signal transduction and cellular vitality. But if it's overstimulated, it actually causes the death of cells. It's pro-apoptotic. And lithium, lamotrigine, and valproate all inhibit this to keep this system more dampened. And it's likely that one of these kind of mechanisms is important in the long-term activity of the drugs. Finally, lithium has been shown probably to increase cellular resistance in a number of models, and possibly also to increase the amount of grey cells in the brain, and this may be due to its effect and through a number of mechanisms, second messenger mechanisms. But the relevance of these mechanisms to its effectiveness in patients is unclear. One of the interesting things is that there's an increase in the amount of grey matter when people are given lithium, and that's shown here in this particular study. After 4 weeks of lithium, the amount of grey matter in the brain increased. And this may be part of the signal whereby lithium is involved in neuroprotection and protecting against damage that may be occurring in affective disorders. So in summary, the drugs have a wide variety of effects on dopamine, on GABA and glutamate, and on the cellular systems. This is the evidence that these are abnormal in bipolar disorder, and this is a summary of what the drugs do. All of the drugs decreasing dopamine to greater or lesser extent, all of them increasing GABA, most of them decreasing glutamate, and certainly glutamate transmission through receptors. There's effectiveness of lithium and valproate on PKC, which is important probably for long-term effects, and also GSK3 beta. And so we're getting closer to understanding the mechanism of action and to the development of newer drugs that have these actions, but don't have some of the complications and side effects of the drugs I mentioned earlier. So that's a brief summary of the pharmacology of the drugs. I'll be very pleased to answer any questions. Thanks very much. Any questions?
Yeah. Great. Now, just while my slides are coming up, just one point. Nicol has gone through lithium and the anticonvulsant mood stabilizers. He also mentioned that we use a lot of antipsychotics and also sometimes antidepressants in bipolar disorder. And if you are wanting to find out more information about the pharmacology of those classes of drugs, then go to the online resource, and in the schizophrenia section for antipsychotics and in the depression section for antidepressants, you can find really excellent reviews of the pharmacology of those classes of drugs. So I'm going to move on to talk about the clinical management of bipolar disorder, focusing on mania, but also briefly covering mixed episodes as well. So declarations of interest. So I've made this point earlier on. I've been involved with a lot of companies, but this is completely independent of industry. I have no ongoing financial involvement with any company. The BAP produce really very good clinical guidelines for the management of different conditions. This is the bipolar guidelines from the BAP. You can download these free of charge. Anybody can download these free of charge by going to bap.org.uk and looking for the published publications and then the guidelines. These were published in 2009 and they are currently being updated. So we've had our first meeting with regard to updating these, and we hope that we will have a draft guideline sometime towards the end of this year. I suspect the revised guideline will probably be published end of this year, beginning of next year. There is also the NICE guideline. I know that a lot of companies do look at NICE guidelines. There is a UK NICE guideline in bipolar disorder published in 2014, and I will refer to this. I think that it is going off in a little bit of a direction, an odd direction at times, to be honest, and I think the BAP one is going to be better. Now, the modern medication that we have available for bipolar disorder really sprang from 1949 when John Cade published his paper, this paper here, in the Medical Journal of Australia about the use of lithium salts in the treatment of psychotic excitement. And it is important to remember that the first indication for lithium, the first indication that was shown for lithium was for acute mania, not for prophylaxis. We think of lithium as a mood stabilizer, but in fact, its first and initial indication was acute mania. Now, I'm just going to give you a couple of quick heads up. I'm not going to review all of the issues around using lithium and et cetera, but I just wanted to highlight a couple of quick points. The first one is one that Nicol has already mentioned, the issues to do with interactions with non-steroidal anti-inflammatories, ACE inhibitors, and the issue that they can increase plasma levels, and it is really important to remember that. Remember, in terms of adverse effects, Nicol has mentioned these adverse effects, but remember that the renal complications that occur with lithium seem to occur fairly chronically and are not just related to having high levels going above 1. They even occur, some degree of renal impairment occurs in the long term, even when patients remain within the therapeutic range. The eGFR measure is a really useful measure for looking at kidney function and making decisions about management of patients, and I can highly recommend this paper here that gives practical guidance as to how to review eGFR results and what to do in different situations. Nicol has also mentioned the issues around toxicity, and very importantly, he emphasized that lithium toxicity can occur even in patients who have a normal therapeutic level of lithium. And the investigation of choice then is the EEG. It shows diffuse slowing and is diagnostic of lithium neurotoxicity. This, together with epilepsy, is one of the key diagnostic uses of the EEG. And Nicol has also emphasized the issues about lithium in pregnancy, but it is so important that I am going to emphasize it again. He talks about valproate, and I will emphasize that again. But lithium in pregnancy, a lot of people have concerns regarding the use of lithium in pregnancy, and it is something to avoid if possible. But one point that I would like to emphasize is that lithium use in pregnancy is associated with this, Ebstein's anomaly, a complex cardiac malformation. Now, this malformation is rare in the general population, 1 in 20,000 as a spontaneous abnormality. It is often quoted that the risk with patients treated with lithium, or babies exposed in utero to lithium, is about 1 in 2,000. In other words, a 10-fold increase in risk. But the important point is this is an estimate. We actually do not know what the risk of Ebstein's is in babies exposed to lithium. And it is probably less than a 10-fold increase. And the important point is that the absolute rate is low, because the absolute rate is probably significantly less than 1 in 2,000 and nearer 1 in 20, but we don't know how close to 1 in 20. So there is an increased risk in children exposed, but that risk is very small. The major issue in many ways with regard to lithium, the major downside with regard to use of lithium, is the fact that if patients with bipolar disorder who are taking lithium and stable on it suddenly stop it, they have a very high risk of rapid relapse of their bipolar disorder, most particularly going high. So this is shown here, comparing rapid discontinuation, which was essentially immediate discontinuation, compared to gradual, which in this study was just over 2 or 3 weeks. And you can see a remarkable difference in the rate of relapse. So the rapidly discontinuing patients, 50% of them were becoming unwell within 3 months, and most of those pretty much within a week or two, a month or so, of suddenly discontinuing their lithium. So this is a major, major risk. And it is really important that when we're using lithium, that we're using it in patients who understand the importance of adherence and that they will not stop it suddenly. When we withdraw lithium, we would normally withdraw it over the course of 2 to 3 months, not 2 to 3 weeks. Having said that, lithium most definitely works. This is a randomized controlled trial of lithium in acute mania, showing lithium being superior to placebo. In this particular study, there was also another active treatment, Depakote, divalproate, valproic acid. And what you can see is that the 2 active treatments were equally effective. And this is an important rule of thumb. The rule of thumb here is that all treatments that work in mania are equally effective. There are 1 or 2 exceptions to that rule, which I'm going to highlight, but the general rule is they are all equally effective, and hence the choice between them is on the basis of side effect profile primarily. So, I've given some key points about lithium, just a couple of quick points about valproate. Again, Nicol has mentioned some of these already. Remember all the adverse effects that occur. I've just picked out a few. Weight gain, we think of weight gain with regard to antipsychotics often, and sometimes forget that lithium and valproate can be associated with weight gain. Alopecia, loss of hair, is an unusual side effect, a relatively rare side effect, but it certainly can occur. And also curly hair growing very curly. And blood dyscrasias and hepatotoxicity. It is worthwhile checking full blood counts and liver function tests probably every 6 months as a minimum in patients who were on valproate. Now, Nicol has highlighted the point about the issues about giving valproate in women of childbearing potential. It is such an important issue, I will re-emphasize it. It is really for three reasons. Valproate is associated with polycystic ovary syndrome, which is why it is important to say this is problematic in women of childbearing potential rather than at risk of pregnancy. So, and this is a particular risk in young women, adolescents and young women. We have the issues to do with the teratogenicity, the neural tube defects, but also this issue to do with cognitive development. And Nicol mentioned that using high-dose folic acid is sometimes done if you have to use valproate in a woman who is of childbearing potential. But the evidence that that prevents the teratogenicity is not there, and there is absolutely no evidence whatsoever that folic acid will protect against cognitive developmental delays in infants exposed in utero, and it is a big effect on cognition. So that led to the very strong statement made by NICE of not offering valproate to girls or young women of childbearing potential. Okay. Now, I've mentioned that all treatments are equally efficacious in the treatment of mania, but there are some exceptions to this, and one exception is in patients who've had a large number of manic episodes. This is looking at the comparison of lithium versus valproate against placebo, both lithium and valproate equally effective. But when patients have had a large number of episodes of mania, then valproate tends to retain its effectiveness. I don't think it's getting more effective as it looks in this graph, but I think it retains its effectiveness, whereas the effectiveness of lithium seems to drop off with a large number of manic episodes. Now, this is purely looking at the number of manic episodes. This is obviously going to overlap with patients who have rapid cycling bipolar disorder, because these patients at this end of this graph are more likely to be rapid cycling patients. But the data as published is specific to do with number of manic episodes. So here is an exception. For patients with a large number of manic episodes, valproate may be more effective than lithium. Now, valproate is an anticonvulsant. So a lot of individuals have looked at a lot of different anticonvulsants to see if they are also anti-manic. And a number of them have been demonstrated to not be anti-manic. This is one of them, gabapentin. And gabapentin, compared to placebo, there was no difference. Gabapentin was numerically worse than placebo in terms of treating bipolar mania. There have also been negative studies with topiramate and with lamotrigine. So we can, with some confidence, say that gabapentin, lamotrigine, and topiramate do not work in acute mania. Let me move on to a different class of drugs, antipsychotics. These are what we have historically used to treat mania for many decades. We commonly used old conventional first-generation antipsychotics before the newer ones became available. This is some data to do with haloperidol. In fact, we don't have lots of RCTs of haloperidol. We do have some data, though, from more recent studies of second-generation antipsychotics where haloperidol has been used as a comparator. And in this data, just a couple of studies, there is a significant advantage of haloperidol over placebo. No great surprise, we've been using drugs like this for decades. So antipsychotics work in acute mania. Now let me come to my second exception to my rule of thumb, that all treatments that work in acute mania are equally efficacious. And this is to do with the degree of excitation or agitation the patient is suffering from. The belief that there is a difference in relative efficacy of different drugs is based upon very little data, but includes this very old study from 1972 that compared lithium with chlorpromazine. And it used a very naturalistic outcomes. It looked at the percentage of patients who remained uncooperative with nursing staff when they'd been given the treatment. Overall, there was no difference between lithium and chlorpromazine, supporting my rule of thumb. But in the highly activated group, chlorpromazine did better than lithium, with fewer people remaining uncooperative compared to lithium, and it was significantly different. So the second exception is that for the highly activated patients, an antipsychotic may be better than lithium. So we know that conventional antipsychotics, I've shown you data for haloperidol, I've just shown you a slide with regard to chlorpromazine. We know these work. But then we also know that the second generation antipsychotics also work. So here is data showing efficacy of olanzapine. And it's important data in that it shows very rapid effects. We see separation from placebo at week 1, with good separation over the course of 3 to 4 weeks. It is an important point when we are trying to assess whether a patient is responding to an antipsychotic in acute mania. A treatment trial really doesn't need to be any longer than a week or two, because we really should be seeing some effect of the drug over the course of 1 to 2 weeks. We do not need to wait as long as we would if we were treating an episode of depression. So here is data for olanzapine. So olanzapine works. And this was an important finding because we know that one of the big differences between the second generation and the first generation drugs was to do with the issue about extrapyramidal side effects and Parkinsonism. And what is clear is that the risk of extrapyramidal side effects with haloperidol seems to be greater in patients with bipolar disorder compared to patients with schizophrenia, which means that it is a really important observation that second-generation antipsychotics work. But it is also important to point out this data demonstrates that the risk-benefit ratio of antipsychotics is different in bipolar disorder compared to schizophrenia. In schizophrenia, there have been studies like Katie from the United States suggesting that first-generation antipsychotics may be almost as useful as second-generation ones, with little difference in overall tolerability. But this may well not be the case with regard to bipolar disorder, where the risk of Parkinsonism and extrapyramidal side effects is higher. So, olanzapine works in bipolar disorder, and we also know that quetiapine does. The company, AstraZeneca, showed a significant separation even as early as 4 days, which is interesting given that you have to titrate the dose upwards of quetiapine. You cannot just start on the therapeutic dose as you can do with olanzapine. Note, in this situation, we're talking about using doses of 600 or 700 milligrams of quetiapine. And we also know that risperidone works. And interestingly, this is a class effect. All antipsychotics seem to work in acute mania because aripiprazole does. And aripiprazole has got a completely different mechanism of action compared to the other antipsychotics, being a partial dopamine D2 agonist. So the fact that this is a class effect suggests this supports what Nicol was talking about earlier on, that hyperdopaminergic state is fundamental to acute mania. We also have the newest antipsychotic that's been shown to work in acute mania is asenapine. And this is data comparing asenapine and olanzapine with placebo, and again, rapid separation, both drugs separating from placebo. Now, there is a little bit of a difference between the asenapine and olanzapine, and I think it's still a little bit unclear to me whether asenapine really is as effective as olanzapine. So whether this is another exception, or whether this disproves my entire rule that all treatments that work in acute mania are equally effective, I don't know, but it just possibly does. Now, that is monotherapy, so we have a range of different treatments: lithium, valproate, antipsychotics, and all of the antipsychotics work. So we've got a lot of different treatments that can treat acute mania. What happens in patients who don't respond to monotherapy? Well, we have data here demonstrating that combination of an antipsychotic plus lithium or valproate is better than lithium or valproate alone. So here we have a number of different antipsychotics, the different colors referring to different antipsychotics, but it's the same message for all of them. There is an advantage of the combination over monotherapy with lithium and valproate. So this is slightly the other way round to the way that we're often doing things these days, because we're often treating with an antipsychotic and then adding lithium or valproate if the person doesn't respond. These studies are done the other way round, so it's in patients on lithium or valproate who have not responded and then having an antipsychotic added. So this led to the NICE guidelines last year, 2014, making the following recommendations. So they said for those patients who are not currently on an anti-manic treatment, if they're on an antidepressant, the statement was, consider stopping the antidepressant. I think in general I would say, stop the antidepressant. Then they say, offer haloperidol, olanzapine, quetiapine, or risperidone. They haven't included aripiprazole or asenapine, and that was primarily on the basis of cost reasons from NICE. There is data, as I've shown you, for both of those antipsychotics. Then they say, if the first antipsychotic is poorly tolerated or ineffective, offer an alternative from this list here. And if this is not sufficiently effective, add lithium. So it's the opposite way round to the evidence base, but that's nice. If lithium is ineffective, or if it's not suitable, then consider valproate. But valproate is very much an afterthought after lithium, and remember the caveats of not using valproate in a woman of childbearing potential. And then they say, don't use lamotrigine. They don't mention other things like gabapentin and topiramate, which also have negative information. I'm not quite sure why, but they said, don't use these drugs which are known not to work in acute mania. And if a patient is already on anti-manic treatment, then if they're on an antidepressant, consider stopping it. Again, I would say, stop it. If they're on lithium, check the levels and optimize it. Certainly you want to be thinking of getting the lithium level around 1 if somebody is in an acute manic episode, and then consider adding the haloperidol, olanzapine, quetiapine, or risperidone. Add the antipsychotic. If they're on valproate, again, consider increasing the dose, and this is a situation where I would then think about looking at the valproate level and maybe trying to get the valproate level around about the 90 or 100 mark to see if that leads to any better control, and then again adding an antipsychotic. So, reasonably straightforward, the management of acute mania. Let's move just on to mixed states. Now, the issue with mixed states is that mixed states are very common. This is some data from the STEP-BD study from the United States. This was looking at patients who are presenting with bipolar depression. But it was looking at the frequency of patients having manic symptoms. So over here, on this left-hand side, 31% of patients had no manic symptoms. But I think it's really quite striking. Only 31% of patients with bipolar depression have no manic symptoms. Over on the right, we had patients who've got 4 or more symptoms that would meet DSM-4 criteria for a full mixed episode, a full-blown mixed episode, which in DSM-4 was they had to have full depression symptoms and full mania, not just hypomania, but full mania. So these patients over here, 15% of them, had full mixed episodes, which left 54%, the majority, 54%, who had got a bipolar depression episode and had at least one symptom of mania, but not a full-blown mixed episode. So very, very common. And DSM-5 then changed the criteria for mixed episodes and said that you could have a mixed specifier for either a manic or a depressive episode. So you can have a predominantly manic episode with some depressive symptoms or predominantly depressive episode with some manic symptoms. And actually that's one of the good things in DSM-5 because it clearly does reflect what we see in clinical practice as shown here. But the problem is, how do we treat mixed episodes? And the answer is, well, we don't really know because we don't really have good data. Most of the data that we have come from studies that were designed to treat mania, pure mania, but had some patients with mixed states that were a subset who've been analysed in a post hoc fashion after the study was completed. We have very limited data with regard to lithium, and what data we have suggests it may not be effective. But I would caution you, it is very limited data. So do not just assume that lithium does not work. It might in some patients, but it would not be the drug that I would go to in the first instance. Valproate may be effective, but it is actually, again, very limited data. But what data there is suggests it may work. Risperidone and quetiapine have very limited evidence for working in mixed states. And indeed, quetiapine had one study in 30 adolescents where it didn't seem to work. And that is a surprise to me, because quetiapine clearly works in mania, and as Nicol is going to come on to, it clearly works in bipolar depression. So it would be an amazing surprise if it didn't work in mixed states. So you have to be cautious in terms of looking at the data. There is some data for olanzapine, but it is very weak, again. And I'll illustrate how weak in 1 second. These are some studies of olanzapine in all patients. So these are patients with acute mania or mixed episodes. They all had to fulfill criteria for a full manic episode. And we can see advantages of olanzapine over placebo in a couple of studies, versus valproate in one study, and as combination therapy versus monotherapy in another. And here we have versus haloperidol. So just try and keep that in your mind's eye and then see this graph. Because this looks exactly the same, right? There we go. This second one is just in the mixed patients. And just flicking between them, you can see that the separation of the drug from placebo, the comparison with monotherapy, is very, very similar. So it looks like olanzapine works. But just look at the numbers. 12 patients here, 12 there, 23, 23. 56, that's a bigger one. 121 here, so that is also bigger. But, 5 and 2. The number of patients is really very, very small. So just be cautious. What they've also shown is that olanzapine continuation therapy also can help prevent relapse in patients with mixed episodes, presenting with mixed episodes, compared to placebo. Note the relapse rate in this cohort was incredibly high. So mixed episodes are a really bad prognostic indicator. So we have some data for olanzapine. We also have some data for aripiprazole. So this was again a post hoc analysis showing advantage here of aripiprazole over placebo in a reasonable sample size, 97 versus 93. So actually reasonable data for aripiprazole. So very difficult. Diagnosis, it's important to spot and identify mixed episodes, but we have very limited data available to us. Valproate may be better than lithium, and we have some limited data, very limited data for risperidone and quetiapine. More data for olanzapine, aripiprazole, asenapine, which I haven't actually shown you. But all of this is really from a post hoc analysis, and we have some longer-term data for olanzapine. So the NICE guidelines were to treat as per manic episodes, but this is inevitable because this data all comes from studies where people were all met criteria for acute mania and then had some depressive symptoms. What we don't have is any data for the other way round. What about patients with a depressive episode and some manic symptoms? And we should monitor closely for the development of a patient switching into the opposite pole. I do think that is important. BAP guidelines are very much avoid antidepressants in these situations. And I think it's something NICE should have said that they didn't. And then finally, looking at treatment-resistant mania. Fortunately, this doesn't happen too often. We see a lot more treatment-resistant depression than we do treatment-resistant mania. But two things to think about. The first is ECT. ECT is effective in treating mania, not just depression, and it is included now in the NICE guidelines as an option for severe and refractory mania. And the other option to think about is clozapine. We've only got case reports, case series, open studies, but we do have some data showing clozapine can be effective in some patients with resistant mania. We would use it in a similar way to the way that it would be used in schizophrenia. So, my conclusions are second-generation antipsychotics, very much the first-line treatment for acute mania. Lithium and valproate are additional options, either alone, but primarily nowadays in combination. Mixed episodes are common, they're very dangerous. They're the episode or the mental state that is most associated with suicide of any in bipolar disorder, and they're poorly studied, and we don't really know fully how best to treat it. Little is known with regard to treatment-resistant mania, but clozapine and ECT are most definitely options to consider. So, I thank you very much for your attention, and